Hello and welcome here at ESC TV at the ESC Congress 2022 in Barcelona. My name is Gerhard Hindricks from the Heart Center Leipzig in Germany, and I have the privilege to share with you what I consider one of the most important and most interesting clinical trials that have been presented here during the Congress on new applications of modern, latest telemedicine and technology to improve the quality of care in patients with cardiovascular disease, the eBRAVE study. And it's my privilege to welcome friend and colleague Axel Bauer from Innsbruck University, who has designed and executed the trial. Axel, you presented eBRAVE yesterday here at the Congress. Can you give us a couple of key elements around the design? What was the concept, the idea behind it? And then we go step by step closer to the results of the trial. What was
it? So I think everybody understands that smart devices might be ideal screening tools. And we have those large-scale studies from Apple, UOI, and these big companies. But these were observational studies, single-arm studies. The recruitment was based on ownerships of devices rather than risk criteria. We have no comparison to the standard. We actually don't know even is digital screening really, has it an added value? And this was the starting point. We said, okay, it needs to be randomized. This is a key element of our trial. We said, okay, we need to include patients who might be in need of screening. Therefore, we approached an insurance company and said, okay, can we select policyholders who have certain criteria? And then we said, making use of the digital technologies, we do a complete digital trial with remote recruitment, communications through a study app, no face-to-face contact at all.
Yeah. So let me stage the wider frame of the trial. So we talk about the trial in the field of atrial fibrillation detection. We know that detection of atrial fibrillation is important because it's often less symptomatic or asymptomatic, that people do not know that they are affected by the arrhythmia. However, asymptomatic atrial fibrillation carries the same risk for stroke and potentially also for heart failure as compared to symptomatic atrial fibrillation. And this is the background for a better detection of atrial fibrillation, to identify people, citizens at risk, to protect them appropriately and adequately. And you have already mentioned that there have been a couple of huge non-randomized company-driven clinical studies in the field, but there has never been data from randomized trials. And so you approach that field going into a randomized trial to identify patients with atrial fibrillation that were previously undiagnosed. Is that true? And what was the methods that you went in?
So that's true. We identified policyholders who were free of AF, had no prescription with oral anticoagulation, but at increased risk of stroke if they would have diagnosed with AFib. And those interested policyholders, this I think is important because we have some sort of pre-selection by this, could download a study app by which they could be informed about the study and could finally provide electronic informed consent. And this allowed us to contact the policyholders, and this allowed us to randomize policyholders. One of the key elements was the crossover design. And during the review process of the study and during many conversations, people always asked, the crossover design is not necessary. Your primary endpoint is after 6 months. Why do you do a crossover design? Don't you understand the simple statistics? And I can tell you the reason. I think it's very important to do a crossover design because when you approach people and are informing people about a study, everybody, I would do this, you would do this, would think about what is my advantage of participating. And if you tell the people, half of you you have a 50% chance that you get nothing. The only thing you need to do is to give your data. Yeah. They say, okay, forget it, at least after the randomization. And we could tell the people, okay, everybody gets the digital screening. It just randomized when you start with it. And
important point, Axel. Yeah. Important point. Let me focus on another important point that was really impressive to me. You performed that trial together with your team without having direct contact to the participants. How did you communicate? So you went to the insurance company data log, you identified patients with the characteristics. How many did you approach, and how big was the size of the populations that you investigated?
Yeah, so this is a very important point, because when we went to the insurance company, only the insurance company was allowed to contact policyholders. We had no contract with the policyholder. We even did not know the name of the participants. So the insurance company approached the policyholders with a letter. Of course, we helped designing the letter, because this letter needed to be convincing. We had to this was also proven by the ethical committee, what is written in the letter.
It's a must.
And of course, and we had a pool of 67,488 policyholders who met these criteria. And out of these, in the end, 5,551 provided informed consent. So this is a fraction, of course, but I was positively surprised, because it might also have been the case that this number is much lower.
Mm-hmm. So the next step was, after you had these roughly 5,500 patients identified, they committed themselves to support you in their trial. Then you advised them to download a specific app that could be used for the PPG signal, yes, to be taken into the smartphone.
Yes. So there were actually two apps. One app which we designed by ourselves was a study app, which included the questionnaires, the information, the informed consent, triggered the randomization, and all these things, the follow-ups. And the other app was a certified app. This was important at that time for the ethical committee, that we used some sort of validated thing. This was a second app. And this by software, this app was only working when participants were assigned to digital screening. So we were sure that participants could not use the app when they were assigned to usual care. But of course, we don't know if participants decide to download another app, or are now aware of AF and went to their doctors and said, okay, I heard about the AF, maybe could you check me, please? Yeah. This might have favored usual care.
Yeah, but it's impressive to see how the study protocol flow was accepted by the patient. There are always the key arguments when you go with new technologies into an older citizen or patient population, that they are too old or too slow and maybe not smart enough to get along with these technologies. I always reject that, because when we take the right approach, as you have shown, when we explain with the right words that people can take it and understand it, they will do. Can you give us a little bit about the characteristics of the patients and a little bit about the compliance during the trial?
Yes. So maybe just one word to your last comment. It's absolutely true. The insurance company, after the trial, made surveys and asked the participants, were satisfied with us, with the study team, were satisfied with the app, with these things and so forth. And the comments were very, very positive. This is the one thing. So participants or people, citizens, are not rejecting digital technologies. If you explain them well, if they work well, they like them. The second thing is, just to this point, sometimes you hear that elderly people are not dealing with these digital technologies. This was not the case in our trial. In our trial, the oldest participant was 90 years old and performed many measurements perfectly. And sometimes even the children helped a little bit with the techniques.
But it works.
But it worked.
It works.
And elderly people tended, or statistically significant, performed more measurements than younger people. So the compliance in elderly people was even higher than with than
I didn't know that, and that's maybe the most impressive second line message from the trial. The older ones were more compliant than
they were really
with an app and with a smartwatch technology.
One old participant performed even thousands measurements in 6 months. So it's amazing.
This is really amazing, and this is beautiful and encouraging for the whole field of digital-driven clinical trials. But now we have to come to the primary endpoint, that is detection of clinically relevant atrial fibrillation. Axel, what did you observe?
So this is also an important distinction between our studies and previous studies, because when we designed the study, I said, okay, we need to prove efficacy. And efficacy means, for me at least, not only detection of some sort of arrhythmia, but also some clinical relevance. In an ideal world, you would show a benefit in terms of clinical outcomes, but this is impossible with our power and design. So I said, okay, we need to couple the AF detection with some sort of clinical impact, and therefore we decided to combine AF detection with a need for anticoagulation or indication for anticoagulation. And this indication, this is important, was not made by the study team or someone. This was made by the local treating physicians across Germany. So the participant with his report after the loop ECG, so I have to say PPG measurement, abnormal PPG measurement, led to trigger the sending and loop external ECG loop recorder, which attached the participants by themselves, sent them back to us. We analyzed it and sent the report back, and asked the participants to consult their treating physician. And the treating physician then looked at the report, looked at the risk factors, looked at the balance between risk and benefit, and decided to implement or to initiate anticoagulation, yes or no. And in some cases I was really surprised, because the clear AF increased CHA2DS2-VASc score, and the doctor said no anticoagulation. So we have to accept it. This was we're not involved in the treatment decisions.
Yeah, we have to accept it, of course, in individual case, but we may intensify our educational paths.
That's true. That's true. But in the trial, it was not allowed to influence the decisions. Yeah?
For good reasons.
Yeah.
For good reasons. So the detection rate was 1.7% roughly in the digital arm, and
in half year.
In half year.
Yeah.
In half year.
In a half year. In a half year. This is important. It's in a half year.
Yeah.
The event rates are not continuous.
Not linear.
Not linear. Therefore, it's difficult to extrapolate this. But in one, if you calculate it for 1 year, it's more than 1.7. It's maybe 2.5 or something. And this is treatment relevant AF. If you look at AF in total, it's even higher.
One of the key advantages of the technology as you have applied it is that you do not need to buy for the patient or encourage the patient to buy a smartwatch or other technology. The citizen or the patient can use just the smartphone that 90% of all of us have in our pockets. We tend to believe, and this is my last question before we open up questions to the floor, we tend to believe that these digital trials are free from complications and side effects, from potential harm. I believe that these trials are relatively safe, but I think it's always important to address that issue. What was your observation, what's your perception in that respect? Looking to your trial.
So in our case, in the case of AF detection, of course, one needs to take care that there's no increase in bleedings, because maybe oral anticoagulations are prescribed freely with no good indication, and the bleeding rates increased. This was not the case in our study. In our study, we observed no statistically significant side effects. But of course, this needs to be checked in future trials and in outcome trials as well.
I couldn't agree more. And the belief that this is not a relevant issue in digital trials is, I don't see it that way. And I know that you have done it. It's a good call from your data that there were no negative observations related to the trial. So at the end, from my perspective, a marvelous study with a new and smart technology application that is almost everywhere available, that has a very balanced risk-to-benefit pricing that proved to be really effective. So congratulations from my side to that marvelous study. It will help to improve the quality of care, the access to care and the quality of care. It will help to reduce stroke rates and other morbidities related to atrial fibrillation. Now I turn to the floor. Are there any questions on eBRAVE? Yes, sir, please.
So this is Göksel from Turkey. I would like to congratulate, first of all, Professor Bauer for committing this excellent randomized clinical trial, and also showing the first time the causality between the PPG-detected AF and adverse event. But apart from this, are there any data regarding false positivity? Because I know this is randomized clinical settings, but what about in real life, where all PPG episodes may not be evaluated by clinicians? Do you have any data for that?
Yeah, we have in our trial during digital screening, 173 participants had abnormal PPGs, and all these participants with abnormal PPGs were evaluated by the ECG loop recorder, or participants went directly to their doctor and the AF was diagnosed in some patients. And if you calculate the diagnostic yield of an abnormal PPG for later confirmed ECG confirmed AF, you end up with a number of 35%. This means that 2/3 of participants with abnormal PPGs have no confirmed ECG with showing AFib. However, it could be the case that these participants have AF, but it is not detected by the loop recorder. It could be intermittent, and even 14-day loop recorder has no 100% sensitivity. And you mentioned our time-dependent Cox analysis showing the association between PPGs and adverse outcomes, and this was significant. So I believe an abnormal PPG, if it's not artifact related, has prognostic value. It's important finding. You should check what is wrong with the patient, with the participant.
Thank you.
Do we have any further questions from the floor? This is not the case, and it seems that we have covered the key messages from eBRAVE. Axel, thank you very much for taking the time and share with us the results in your perspective on the marvelous eBRAVE trial. And thank you very much for your interest in ESC TV. Bye-bye.
Thank you very much.